scientist and he was hopeless. So rocket science is overrated. He couldn't even spell DNA. It was just kind of a mess. But I hope none of you are rocket scientists. But first of all, if your blood counts are better when you get MDS, obviously that's better. If you're not needing blood transfusions, that's better. When somebody looks at your bone marrow and they look at the number of early cells, we call them blast cells, well, lower blast percentage is better. It's a little bit less aggressive. If someone says you've got no cytogenetic or no genetic abnormality in the MDS cells, in general, that's good. There are lots of exceptions to this, but this is a sweeping generalization. About half patients will have normal chromosomes, and in general, that's a little more favorable. Patients who are younger do better with MDS. At the same time, they're younger and they've got a difficult disease, so it's sort of a mixed balance there. And finally, something that we don't really emphasize enough in prognosis, but somebody's ability to function, to drive, to shop, to shower on their own, to dress themselves, their functional capability, turns out to be very important prognostically, and we don't spend enough time trying to help people with their comorbidities to improve their functioning status. Now, I'm going to go through these systems, but I have 2 slides of caveats, and I'm going to bring this up several times. Prognostic models, many of them are derived from patients who never got treated for their MDS before we had active treatments for the MDS, and therefore it's what happened before, not necessarily what's going to happen now. Okay? Second of all, they don't give credit for the beneficial effects of modern treatment. We now have approved drugs in MDS. We've had less than 10 years of experience with that, so many of these are from studies before that. We have better antifungal antibiotics that help people get through difficult infections. We can get more people through stem cell transplant, even people over the age of 60 or occasionally up to 70. So we don't always credit the ability to use reduced intensity conditioning into what happens with prognosis. And we can do things to minimize the long-term effects of iron. We can do iron chelation to minimize these effects in people who are getting regular transfusions. So even the numbers I'm going to show you today or the models I'm going to show you today don't account for the improvements. So I want you to be a little careful how you interpret them. This is more to help you understand them than to interpret them. Prognostic factors may affect treatment decisions. Sometimes somebody has a deletion 5. Sometimes that helps you, even though there's a prognostic upside or downside with it, helps you get a targeted treatment with lenalidomide. If somebody has getting transfusions or a higher IPSS score or their functional ability is impaired, they may not respond as well to Vidasa. So they sometimes impact how we give treatments or what happens with treatments. And I've said this already, but we have to consider the functional ability and medical history of a patient. This is a question that came up in the last presentation. And there's evolving studies saying that people who've got heart disease, liver disease, kidney disease, pulmonary disease, or who've had a cancer in the past, all of these independently impact on MDS prognosis despite what the MDS is doing. And it stands to reason. If you've been through more and your body's not as strong, it's going to be harder for you to get through things. And that's where we have to balance it. This was not well studied in the past. Now, the original classification, I say original, this is only 30 years old, but the original classification of MDS was called the French-American-British classification, and it was really just based upon how the MDS looked under a microscope. Did they have something called refractory anemia, or were there ring sideroblasts? Did they see an increase in the blast count to over 5%? That's called excess blasts. If it's over 20%, that was called excess blast and transformation, and I'm not going to touch much on this cousin disease called chronic myelomonocytic leukemia, CMML. But when you look under a microscope, just how the MDS looks under a microscope, if you see that there's, depending what the blast count is, gives you an idea what the survival is going to be in these different cases. So it was really the first appreciation that we could start to say, how does it look under the microscope and how's that translated in the clinic? Fairly crude. We still use some of these features, not an exact science. Now, I took this from the American Society of Hematology website. They'll have images you can download. And just to show you, this is a bone marrow aspirate of somebody with refractory anemia and excess blasts. Somebody trained with a microscope has to go through and count all these different kinds of cells and determine for each cell, does it look damaged or not? Is it a blast cell or not? And it turns out, even if experts all look at the same sample, they don't come up with the same blast percentage. There'll be a degree of variance, as you'd expect. So it's not a perfect science. They don't have a little B on them that says blast. You have to determine if they're a blast or not. So if someone says you've got 10% blast and somebody else says you've got 8% and someone says you have 15, it's not precise. There's going to be a range there. We can tell when they're a little elevated, a lot elevated, or when they've moved to leukemia. I'd say that's fairly accurate. Nothing happens magically when you go from 9% blast to 10% blast, but in some systems that bumps you up into a slightly worse prognosis. So you have to take it in context. Many times a hematologist or a pathologist will call it excess blast based on flow cytometry, but that's actually not accurate. You have to count the blasts. So just to let you know, it's not an exact science. There's some wiggle room in it, and we appreciate that in the clinic, even though we tell you it's a fact. It's a fact kind of like the facts you heard at the recent conventions. Sorry, I'm Canadian, so I get to have this, I get to stay above the fray. But if you just look at this system, this is from a paper that's 15 years old, and I'll come back to this paper in a minute. But when they just looked at a group of patients, 800 patients, and they classified them, they could see there were differences in survival based just upon how it looked. And the most important thing is this green line. If you had an increase in the blast count or a severe increase in the blast count, people didn't live as long. This was before we had active treatments, but it spoke to the fact that the disease was more aggressive as the blast count went up. Now, this is just an example of somebody's chromosomes. Chromosomes are numbered from largest to smallest. And what happens is that it takes a technician about 4 hours doing nothing else. So a technician can do 2 chromosome samples a day. It's a hard thing to do. You have to stain it, separate them, line them up, look at the bands, count the bands. In this case, you can see in chromosome 5, when they lined up chromosome 5, truthfully, I have a hard time differentiating chromosome 5 from chromosome 4 or from chromosome 6, but that's just me. You can see if there's a large deletion and the rest of it lines up. That's fine. A large deletion is going to be obvious, and you'll get that. On the other hand, small abnormalities or subtle abnormalities can sometimes be hard to pick up. So I'm not saying it's not an exact science, but it's really hard to do cytogenetics. It's very expensive, kind of a money loser for labs to do them. It's still really important we do them. And subtle things you miss, or subtle things we wouldn't pick up on it. So I just want you to know cytogenetics isn't, even though it's a core test, isn't always perfect. Now, we know that not everybody has a cytogenetic abnormality. When you send cytogenetics, at least in Germany and Austria, about 98% of the time they get a successful result. At the place I used to work before, it was running about 85%. And I said, well, why are we sometimes getting cytogenetics that just say failed? Why isn't your lab doing a better job? And they said, because you're not sending a good sample. And so we would sort of fight about whether I didn't send a good sample or they didn't do a good job. Obviously, in Germany and Austria, they follow the rules and they get good samples. But the point is that about half the time it'll be normal and about half the time it'll be abnormal. When it's abnormal, most of the time it's a chromosome 5, but it can be anything on this list, sometimes by itself, sometimes with other abnormalities. And so about half the patients will have a so-called good chromosomes, which is normal, and the other half will have an array of abnormalities. Some large studies, this is one of them. There's another recent one by Dr. Greenberg that's on Blood Online. In very large studies, we pick up these really rare abnormalities that might be very favorable in people who don't need treatment. And so one of the things we've learned about these international collaborations, Dr. Neimer in the room and others have been involved in these collaborations, is that you get more powerful with more data, and you can pick up some very unusual or very rare abnormalities that we didn't appreciate in the past. So what we do now, what's commonly done for prognosis, is we look at the morphology, which is how it looks under the microscope. We add the degree to which the blood count, the complete blood count, the CBC, is abnormal, and we look at the chromosomes, the cytogenetics. And we come up with a scoring system. This was a really important paper for us 15 years ago that gave us what we call the International Prognostic Scoring System. And you get a score based upon karyotype, cytogenetics, and chromosome are all the same things. And we just like to sound fancy by using different words for it. But really, they're all the same things. And cytopenias just means how low are your blood counts? Is it just one blood count low, 2, or all 3 lineages low? So you get a higher score when you do this. And as your score goes up, the risk of the disease misbehaving goes up. That means the risk of you having trouble from it, the risk of it turning to leukemia, or the dangers of the disease go up. And you end up with something like this. Now, this was before we had active therapies that were FDA approved. This is, again, the same paper 15 years ago, but it's commonly used, this International Prognostic Scoring System. Look at all comers. Patients with lower risk had a much greater median survival than patients with high risk. And actually, the patients with high-risk features, if you don't give them treatment, have a survival similar to acute leukemia. That's a very dangerous disease. We now have treatments for it. In general, We call low or intermediate 1 a lower risk MDS, and in general we call those intermediate 2 or high, would have a higher score, a higher risk MDS. In this system, more than 2 out of 3 patients had low risk features. And so this is something I'll come back to in a minute. We're trying to figure out in that low risk group who's going to do better and who's not, and who's got the high risk, low risk, and whether that's a group we should try to do more for. So I'm going to remind you again, these were untreated patients, and they don't reflect the modern benefits of treatments, antibiotics, transplant, or iron chelation. Now, there is a revised version of the IPSS that's actually published. You can find it on Blood Online if you want, and it's an update of the last one I just showed you. What they did is they got over 8,000 patients. That's true, 6,000 patients. They actually broke the cytogenetics into more categories. They actually gave weighted scores for the blasts and weighted scores for the cytopenias. That's hemoglobin, neutrophils, and platelets if they're running low. And they came up with a more complicated system for what's a very good, a good, or a poor cytogenetics. A really important point, though, is that 65% of people had good cytogenetics. So most people have a normal or favorable cytogenetics, which doesn't always help so much in determining differences. In this revised score, they now have 5 groups instead of 4 groups, a very low risk, a very high risk, and then these low, intermediate, high in between. And you can see this spread where people with very low, this is without therapy, before we had active treatments. People with very low had a better survival than people with very high. This is the risk of transformation to leukemia. It goes up in the highest risk group. And so, actually it has over 6,000 patients in this. So we have a slight tweak to that system of what are the chromosomes, what is your blood count, and what is the blast percentage. But it's essentially still the same thing with just more detail. So whether this gets used more often or not, I don't know. It's kind of a derivation of what we're using already. Same caveats I've told you. These were untreated patients. Don't reflect the advances of modern treatment, as you can see in the list here. Now, it's been appreciated for a while that people with MDS who need blood transfusions have a harder time. Their MDS misbehaves more. They have a shorter survival. Some of us think that that's from the blood transfusions. Some of us think that's because the disease is worse and needs blood transfusions, and some people think it's a combination of both. I guess I'm in that last group. But it told us that getting transfusions suggested a higher risk MDS. Not in everybody, but in average, on general. And so people, a European study actually, several years ago, said, well, should we integrate transfusion requirements into the prognosis? Instead of just doing blasts, blood counts, and chromosomes, should we also add whether somebody is regularly requiring blood transfusions? And they came up with a scoring system called the WHO, the World Health Organization Prognostic Scoring System. Now, not many of us in the States use this routinely in practice. Many in Europe do. It does have the advantage that it appreciates the importance of blood transfusions. But I wouldn't say it's a big step forward from what we're using already. So I'd say it's an advantage. If you need blood transfusions, it's a little worse. But you're really going to get similar numbers as with the system we have already. Now, I think a bigger advance was a study from the MD Anderson Cancer Center in Houston, where they actually added more variables. They said, well, let's look at the patient's performance status, their functional ability. How low is their blood count? Are they getting blood transfusions, as well as the other factors of cytogenetics and blast percentage? And they call this their simplified risk score. Now, when you've got these coefficients, it doesn't look simplified to me, so I actually put the simplified in quotations. I don't actually think it's simplified, although many of us use this now. But it actually gives you credit for the fact, or it accounts for if somebody is depleted from other diseases and not functioning well, they're not going to do as well. If the platelets are extremely low, that's more dangerous. If the hemoglobin is quite low, that's more dangerous. And if somebody's getting blood transfusions regularly, that actually speaks to the disease being more aggressive. So it's trying to bring more things into the prognostic model and not be one-dimensional, be multi-dimensional. What they found when they did this was that 60% of the patients had higher risk features. If you start to look at functional status, how low the platelet count is, and excuse me, and the other factors and the transfusion requirements. So they were able to find Dr. Kintarjan and his group. I think this is an advance for us in our understandings of who's higher risk and who's lower risk, because instead of it being 30%, with our regular system, about 60% of the patients have higher risk features. And that feels more right to us because we know more patients get into trouble than just the 30% with higher risk disease. Now, this has been, was studied at MD Anderson, was confirmed at a study at the Moffitt, was confirmed with a study at Mayo Clinic as well. And we got very similar results, all of these sites together, showing that with an updated system, we could better break patients down, and more patients had higher risk features. There's an important component on this slide, which is that this group doesn't do very well. This is the high-risk group with this MD Anderson model. But the average survival is 19 months with the high-risk group, and it was less than 6 months with the original study. So already you're starting to see that some of the advances of modern therapy are creeping in, and people who used to not live more than 6 months on average are now pushing towards 2 years on average. So I think an important recognition of this is that we are seeing some benefits even in the high-risk group. It's not enough, it's not good enough, but we're making progress, and this is already a couple of years old. In this study, a quarter of the patients who had lower risk in the other strategy now have higher risk, intermediate 2 or high risk. And I think this is going to help us find more patients who would benefit from treatments, and we have treatments that improve outcomes. So this is a really complicated slide, but the point of it is to say that there's different models. This first model, this WHO model, the MD Anderson model. I'm not going to talk about that category, the CMML, but some of them, like the MD Anderson model, accounts for whether it's secondary, whether somebody got it because of previous chemo or radiation, whether it includes previously treated patients, whether it actually has a sensitivity to how low your blood counts are and whether you're needing blood transfusions. Doesn't really have much in children. It's an area that we still need to develop, and breaks the chromosomes into different categories. It's hard to say one's better than the other. I would say that this is the one that's most used in the country and most used in research studies, but I'd also say this is the one that many of us in academic centers are using to really try and get a better feel what's going to happen to our patients. Now, if you want to know the whole list, this is a slide David Steensma, who's a friend who studies MDS in Boston at Dana-Farber, sent me. These are all the different prognostic systems. So it depends on whether you're, I guess it's sort of like which soccer team do you like, you know, the British or the Dutch or the Spanish. You can just pick whatever one you want, and they all give the same kind of idea of breaking patients who've got lower risk or higher risk disease. And so one of the problems we've struggled with is which is the right system, which is the best system, because there are many different options, as you can see on this list. And I would say right now, the original international prognostic scoring system is that most of us talk about in studies, or the MD Anderson model at cancer centers is what many of us are using to identify high-risk features in the MDS. Remember, most of these are untreated patients, and most of these do not reflect the beneficial effects of therapy. So I wouldn't want you to personalize this too much for you or your family member, just to give you an idea of what the factors are that we're trying to account for. Now, there's been significant advances in our understanding of the genetics of MDS and what gene mutations are there in MDS and how that impacts patients, and maybe how we can treat MDS in the future. This is important. You should care about gene mutations in MDS. We can't really measure them for people yet outside of a study, but you should care about them because it's going to give us clues about what went wrong with the MDS cells in biology. You just heard from Dr. Kogel's presentation that some of the work he's doing in genetics and in the markers of the MDS cells is leading him to new therapies and advances, and that's going on at other centers as well. So that's important. It's helping us diagnose MDS and differentiate it from other bone marrow diseases, or at least it will. It's giving us an idea in prognosis. It's already being used, gene mutations in some other cancers, like in acute leukemia, to help us determine prognosis, and we're hoping to be able to get more information with that in MDS and move it forward. And in other leukemias or bone marrow cancers, mutations help us pick the right drug, and we actually can get specific drugs. And so you heard an example of that earlier this morning. There are many more examples like that where we're using the abnormalities in the MDS cells or in the genetics to try and come up with more targeted treatments. So I think this is going to help us develop new targeted treatments or better use the treatments we have available now so that we can know who's going to get the most benefit from them. Now, the first time I put this talk together, I had about 15 slides on gene mutations, and I thought, well, I don't know, how much do they want to know? And how much do I know? And do I know enough? And the simple thing is that a mutation is when you have a normal cell, when you've got DNA that's wound, and DNA goes in order of the different nucleosides, whether one of them gets switched from A to a T or C to a G. And when that happens, the DNA doesn't get read properly, the protein doesn't get produced properly, the protein that's made doesn't function properly. Now, we don't know why that happens. We don't know why people develop mutations. It could be because you had chemotherapy and that stressed your DNA in some cells. It could be because your cells grow every day and make mistakes when they grow anyway. Lots of reasons why people can get that. Could be from all the other reasons that have been talked about already this morning. Most of the time, in fact, the very large percentage, these are not mutations you're born with. There was one example you heard of this morning, very few examples of hereditary MDS. Most of the time, these are just mistakes in your blood cells, damage to the blood cells and the stem cells when they're growing, a focal mutation, and an unlucky one that actually causes that gene not to work properly, and then suddenly things go awry in the cells or in the bone marrow. So a mutation is when you get a single abnormality, but it changes how those proteins work all of a sudden. Now, that was just an example. It doesn't have to be a C2, whoever said that. It doesn't have to be that one. That was just an example of a mutation. But there are some mutations that are present in MDS and that might affect MDS prognosis that we're just learning about. This is a paper published last year and presented the previous year at the hematology meetings that looked at mutations in patients with MDS. And in this study, they found mutated genes, 18 mutated genes. In fact, about half the patients in their study, they had over 400 patients in the study, about half these people had a mutation in the MDS cells in their bone marrow. And they saw mutations in genes that we know, the P53 gene, EZH2, ETV6, RUNX1 you heard about already this morning, the ASXL1 gene. These are genes that just look like letters to you, but they have important functions in your cells. These are all just abbreviations. And some of these had independent prognostic impact. In fact, these mutations, there were more mutations found, TET2 mutations and NRAS mutations. And this is a list of genes that we all have in our cells. And when some of them were mutated, it seemed to make the cells grow worse and seemed to worsen the prognosis. So I didn't want to go into too much detail. There are other genetic abnormalities, SF3B1 and others, that we're learning about in MDS that we don't know how to target yet, that we're learning what the frequency is of them. They're not something we can test for in people yet. I don't think that's many years away, but it's not there yet. And we don't quite know what to do with them in people, but in a research study, we're trying to learn what the implications of them are. So I wanted to let you know there are many classification systems, but for now, many of us are sticking to the basics, either the IPSS or the WHO classification. Cytogenetics, about half of people with MDS will have abnormal cytogenetics. They're still very important and help us guide treatment. There are lots of new molecular abnormalities, but they're not ready yet. They're not available yet for prime time. Stay tuned, because in the years to come, and not many years, we're going to know a lot more about them. If I needed to simplify MDS prognosis, it's something that was understandable and as a take-home message, it would be use the blood count, the blast count, and the cytogenetics. I would add a star there saying account for the strength and stamina of the patient and what other diseases they have and how that's affecting them. If you had lower risk disease, the IPSS lower intermediate 1 in the score, we treat that differently than patients with higher risk disease. Higher risk disease is either having an increase in the blast count or higher score on that system. I'm going to stop there and answer any questions you have. Thanks.